At the outset, let me thank Dr. Georgie Nanan for first providing us with this platform for interaction and of so benefit to dialysis technicians as well as staff, as well as practicing physicians, which so many important discussions are going on now the last couple of years in this platform. So let me also thank MQ for their wholehearted support for this academic program. So, as Dr. Vilesh has mentioned, fever is a vexing problem for all clinicians. So, for the patient in the dialysis unit, the reason for the fever can be a very negligible or very of mild consequences, rather than it can be a very life-threatening sign or of the early indicator of a life-threatening problem. We had COVID-19 first in our minds for the last couple of years or 2 to 3 years earlier. For any fever which occurred in the dialysis unit was considered to be COVID, and all the others were in the background, or were given, all the other causes were given a second slot only. But now the COVID fear is over. We hardly ever consider COVID or in our patients, or consider significant in our patients. So with this background, I will just say what is basically how will you define fever? What is the range of normal temperature? So the normal temperature is considered 35 to 37, 34.3 to 37.7 degrees Celsius, or 95.5 to 99.9 degrees Celsius, an average of 36.7 when measured orally. It's an elevation. The defined fever is an elevation of a core body temperature above the daily range for an individual. A morning oral temperature more than 37.2, or an afternoon temperature, because there is a diurnal variation, more than 37.7 could be considered as a fever. In practice, any temperature, I think more than 100.4, 100 degree Fahrenheit, is often used to define fever. So what are the causes of fever to start with? So it can be either infectious or non-infectious, strain pain. It can be either infection or non-infectious. So infection related in a dialysis patient, first and foremost, is vascular access related. And any other causes that can cause a fever in the general population occur with much more vigor, and it causes much more morbidity in the dialysis patient. There's bronchopulmonary infections, genitourinary tract infections, gastrointestinal, abdominal, skin and soft tissue, CNS infections. All these can happen in these patients. And there are a whole lot of non-infectious causes which can mimic infections or which can present as fever. One is malignancies, especially lymphoma, reactivation of primary diseases, drugs. Drug fever is as the prescription pattern of our patients contain a whole lot of drugs, something numbering around 10 to 12 many a time. Drugs are a very common cause of fever. And chronic inflammatory disorders, which many times result from the persistent inflammatory state that these dialysis patients are in. So why they are significant? Why you consider infections as significant? It is the second most common cause of death among hemodialysis patients. As we all know, most of our patients die due to cardiovascular disease. And this is the second most common cause of death. And the mortality due to sepsis occurs about 250-fold more common in dialysis patients compared to the general population. So the major independent risk factors for mortality due to infections are: one is diabetes, older age, comorbidities, other, say, cardiovascular disease, liver disease, hypoalbuminemia, and one of the largest studies have shown in use of a temporary dialysis catheter as one of the major independent risk factors of death from infections. So this is a large, all in dialysis should know this study, HEMO study, and this is one of the offshoot papers come out of HEMO. That's a frequency of infection-related outcomes. So the infection-related hospitalization death was one of the, compared with one of the largest cause in all-cause mortality and hospitalization in dialysis patients. So why are dialysis patients more prone to infections? There are chronic illness, immune sufficiency, they are neutropenic, malnourished, low albumin levels, extremes of age, and iron overload. I'll come to that again. That is why many of these patients get iron iron infusions. They are on the as our geriatric population also increasing. the patients on dialysis above 80, the numbers are also going up. The proportion of patients that are more prone for infection is also increasing in our units. So the process of dialysis requires a frequent use of catheters. Here, bloodstream or the blood vascular compartment is tampered quite often. So there is a frequent use of catheters, there's insertion of needles to access to the bloodstream. And very often the infection through these routes is spread by the hands of all of us, by the hands of healthcare workers. And these patients hence have an increased risk of getting a healthcare associated infection. There are other factors which are procedure related. There are improper machine surface cleaning, improper disinfection of the machine fluid path, damaged transducers or reuse of transducers, improper dialysate use, not following universal precautions, and poor quality, water quality, or a poor dialysate quality. So first, coming on to the dialysis catheter-related infections, can be the local site infection, or which can be the divided in exit site or tunnel infection, or so-called catheter-related bloodstream infections, or CRBSI, as they're called. And majority of bloodstream infections in patients in hemodialysis are caused by infection of vascular access catheters. So as we all know, the best way a patient can be dialyzed is through the arteriovenous fistula, and second best is arteriovenous graft, and third is a perm cath, and fourth is a temporary temporary catheter. So this is the main reason why it is so. The infection of vascular access catheters is the main cause of bloodstream infections in patients on dialysis. And comparing it non-tunnel versus tunnel is 3 times more common in the non-tunnel. And the episodes even in a tunnel catheter is 3 to 6 episodes per 1,000 catheter days. So 1 to 2 infections is almost universal in the first year of permanent catheter. So to define the CRBSI, it is defined as bacteremia or fungemia in a patient with an intravascular catheter, and where there is no apparent source for the bloodstream infection exists except the catheter. And at least you should have 1 positive blood culture obtained from a peripheral vein. There should be clinical manifestation of infection like fever, chills, with or without hypotension. And the best, to satisfy the definition, the best way is to get the same organism isolated from the catheter as well as the peripheral blood. So this is again one of the large studies with more than 8,000 patients. The crude modality rate attributed to infection by the vascular access type was studied, and here the majority, the maximum number of patients who died was with the curved catheter, and compared to uncuffed catheter, because here it was the majority of patients who started dialysis with the cuff catheter, and the lowest was the fistula, and the intermediate mortality with the AV graft. So that is why a catheter has to be dealt with care with utmost caution. So again, I will just reiterate the risk factors of CRBSI. If somebody who had a history of previous CRBSIs are highly, the chances increase to get a CRB infection again. Recent surgery, diabetes, iron overload, or hemostasis, immunosuppression, hypoalbuminemia, and extremes of age. And some of the factors related to the catheter type, the tunnel versus non-tunnel, the duration, the longer the catheter, the higher the incidence of infection. Location, femoral catheters are the maximum instance of infections. Not taking barrier precautions, the improper catheter site care. When they have a dysfunctional catheter, we have to manipulate the catheter more often, and this can cause higher infections. Thrombosis of the catheter again will cause a poor flow and gets manipulated much more, and the infection risk are higher. Septic foci elsewhere, anywhere in the body, say be the throat, an abscess elsewhere, the osteomyelitis, all those the catheter can get colonized by the bloodstream bacteremia. So what are the organisms? One is the coagulase negative staph and staph aureus. The gram-positive organisms account for 40 to 80% of cases. The skin contaminants. The gram-negative organisms like Klebsiella, Pseudomonas, all to 20 to 40%. Polymicrobial, more than one organism getting in 20 to 20%. As the catheter grows older, the chance of polymicrobial infection also increases. How does the infection reach the catheter? The migration from the skin along the outside of catheter is one mechanism, and secondly, direct inoculation from biofilm containing pathogenic microorganisms can form the inner surface of the catheter. So here is an early infection. Is very often it can be early within 48 to 72 hours of catheter insertion. Is very often due to skin contamination via extraluminal route of bacterial injuries. Most often due to improper skin care before access insertion. So it's late infection, mainly due to improper cleaning or touch cup contamination, and this is due through the lumen. The bacteria enters the catheter through the lumen. So other reasons, one is inadequate dialysis reprocessing procedures. I'll come to that again at the end of this talk. Inadequate water treatment, contaminated medication vials. There have been crops of infection, epidemics with heparin vials getting infections transmitted through heparin vials, and there are many reports in literature. Second is endogenous. There is resident microorganisms, and as we all know, nose is one of the main sites of harboring Staph aureus infection. And there have been studies that shown nasal mupirocin can reduce the infection rate in patients. And again, non-compliance. Somebody who is reluctant to compliance, a health worker is reluctant to compliance with infection control precautions or universal precautions. So this is, in short, this is a contaminated catheter cup in the skin flora or extensive in the healthcare worker hands. Hematogenic from distant infection. And endogenous, here again, on the skin excision site or the skin excision site is the same. It can be endogenous in skin flora or extrinsic from the healthcare worker hands or a contaminated field where the skin is infected or improperly cleansed skin surface. So the clinical manifestations is all of us that are in a dialysis unit have seen this, fever or chills, and most cases occur in the absence of an exit site infection. And these patients many times can have hypertension, the blood pressure will be low, hemodynamic instability, the heart rate will be high, the increase, the blood pressure will be low, altered mental status, tiredness, catheter dysfunction, and other signs of sepsis, as low temperature, acidosis. And at the later stage or in severe infections, especially Staph aureus or fungi, they can have separative thrombophlebitis, endocarditis, septic arthritis, osteomyelitis, abscess, or even epidural abscesses, epidural infections can happen from catheter-related bloodstream infections. Anywhere where the blood flows, it can deposit, it can seed there and cause infections over there. So it can be should be suspected in any patients with a hemodialysis catheter and signs and symptoms of a systemic infection, particularly when there is no clinical evidence for an alternate source. Should be confirmed by 2 blood cultures obtained prior to the administration of antimicrobial therapy and after exclusion of alternate source of infection, and one of them from a peripheral vein. So here, how to take the cultures? If the patient develops symptoms shortly before their next hemodialysis session, you take one from the hemodialysis catheter when you start, and the other from the peripheral vein or the hemodialysis circuit bloodline when he is on dialysis. If he develops it during a treatment, because the interdialytic period is normal and he develops fever chills during the treatment, you take 2 samples, one on the peripheral hemodialysis circuit or 1 sample from the circuit and 1 from the peripheral vein. Thirdly, if he develops symptoms at home during the interdialytic interval, you take 1 sample from the hemodialysis catheter and another one from the peripheral vein. So second is, should he remove the catheter after if his CRBSA is confirmed? So the best catheter management method is immediate removal of the infected tunnel catheter. And there are few reasons. One is or few indications. One is persistent hemodynamic instability or severe sepsis, infection elsewhere, the same infection metastasizing to elsewhere, and there's a severe exit site infection. An insertion site infection again that should prompt a catheter removal. And in this such a situation, a gateway exchange is not appropriate. As the skin site is infected, it can lead to bacteremia and septic emboli. And you have to take cultures from the exudate around the site of insertion, as well as blood. The tunnel infection is another form of infection, whether it's erythema, tenderness, and induration can overlie the subcutaneous tunnel tract, which extends more than 2 centimeters from the, extends more than 2 centimeters from the exit site, and with or without the signs of exit site infection. There can be local reaction, but it need not be there always. And tunnel infection mostly is treated with catheter removal. If there is a pus collection or there's an abscess over there, you have to do an excision and drainage along with antibiotics. So the antibiotic therapy, one of the guidelines suggests the empirical antibiotic therapy with covering both gram-negative and gram-positive organisms, vancomycin plus ceftazidime, which is modified by culture results. If it comes to Staph aureus with sensitivity results, you modify, you try de-escalation or limit to one antibiotic. If the patient is anuric, you can move over to aminoglycosides, so gentamicin, tobramycin, or amikacin, because the dosing can be made very convenient. So how long you should give antibiotics? The optimal duration is uncertain, but then you somebody with a complicated catheter-related bacteremia, you have to give at least 6 weeks. Complicated means there's an evidence of a metastatic infection or there's a persistent blood culture positivity. You do give antibiotics for 2 weeks, so repeated blood culture, you get again the same organism in the culture. You have to remove the catheter because you are not going to eradicate it by antibiotics alone. So the next is uncomplicated catheter-related bacteremia. If it is not, there is no abscess, infection, the fever, the blood culture, repeat blood culture is negative. There is no fever, and the dialysis has been being uneventful. So in 3 weeks, 2 to 3 weeks, if the catheter has been removed and replaced with a new catheter and salvaged. And in certain infections, especially Staph aureus, you have to give antibiotics for at least 4 weeks. So second is to prevent removal of the catheter. One of the methods is by antibiotic lock therapy, which consists of a combination of antibiotics and heparin. So it is designed to kill the bacteria present in the biofilms in the catheter adherent to the catheter lumens. So you can use a high concentration of antibiotic. The commonly used is one is vancomycin. You can use cefazolin, ceftazidime. All those mixed with 50 to 100 ml of saline, mixed with heparin and prepared immediately before being instilled into each catheter lumen. And you have to continue for at least 3 weeks. And many a time it allows salvage of the tunnel catheter. There can be other infections can be associated. It need not be always a catheter-related infection. So one of the commonest infection other than a CRBSI in a dialysis patient is respiratory tract infection. So ESRD is associated with higher mortality in RTIs, respiratory tract infections, especially those with pneumonia. And of course, COVID-19 was deadly, and especially with related to the respiratory system in dialysis patients, and many of us lost a number of patients with that epidemic. Bronchitis and pneumonia are the commonest infections in dialysis patients, and more difficult to diagnose because these patients present with breathlessness, and the X-ray, the pulmonary fluid fluctuates markedly with dialysis treatments. So you have to be very clinically judicious in making a diagnosis of pneumonia in these patients, especially when there are no other systemic signs. So the presence of a productive cough with yellowish sputum, or hemoptysis, or fever, chills, pleuritic pain, or dyspnea, and suggests infectious pulmonary process is confirmed by blood tests, sputum evaluation, and chest radiograph. The other infection is again very commonly seen in dialysis patients when compared to general population is central nervous system infection. The fever with CNS signs or findings. So confusion, altered behavior, neck pain, headache, along with fever in a dialysis patient should warn us about the presence of either meningitis or encephalitis and properly evaluated with a CT MRI scan and lumbar puncture and CSF analysis and appropriate antibiotic therapy instituted. The GI symptoms, again, many of them are much common, especially gallbladder and biliary disease, cholecystitis or cholangitis, pancreatitis, hepatitis. Again, many of hepatitis C and hepatitis B are commoner in the dialysis population compared to the general population. Diverticulitis is a finding commonly seen in autosomal dominant polycystic disease patients, and they present with fever and abdominal pain or bowel symptoms. Peritonitis, not only in chronic ambulatory peritoneal dialysis patients, so those patients improperly dialyzed, those patients on dialysis, patients with liver disease on dialysis, all those can have the patient with fever, abdominal pain, and a worsening abdominal symptoms. Then peritonitis has to be thought of. And those patients who are on antibiotics for a long time, again, person with fever, with worsening abdominal pain, colitis due to Clostridium difficile or pseudomembranous colitis has to be thought of. So, urinary tract infections associated with urinary catheterization, so-called catheter-associated urinary tract infections, are among the most common nosocomial infections among hospitalized patients on chronic dialysis. So, you tend to put a catheter when the urine output is low in many situations, and that can be the main reason for a sinitis or infection in these patients. So, those patients, the residual urine output, they can have dysuria, again worsening abdominal pain and fever. And many of those patients are anuric, dialysis patients are anuric. So the symptoms can only be a bladder discomfort with or without a fever. So the candidate is to be treated with antibiotics, and many often the antibiotics has to be adjusted as per the recommendations for the renal dosing. Skin and bone infections, again a significant cause. Most of our patients are diabetics with peripheral vascular disease and congestive cardiac failure. So cellitis with those patients with peripheral neuropathy, and many of them, they go unnoticed. And it's an important cause of morbidity in patients on dialysis. The diabetic foot infection spreads rather fast in these patients, and unless taken care of early and properly, can lead even to amputations. And this can even extend the cellitis or CR can extend into the bone, causing osteomyelitis. Osteomyelitis also can happen in these patients from the hematogenous spread to a catheter-related bacterial to infection. So, all of us are aware of calciphylaxis when there is a arteriolar occlusion and causing extensive necrosis of the skin tissues. So, calciphylaxis can be secondarily infected and again can cause significant morbidity in these patients. So the ESRD undergoing chronic dialysis are much more prone to develop tuberculosis. The incidence of tuberculosis among many studies has shown the incidence is 5 to 10 times compared to the general population. It's difficult to diagnose because many of the symptoms, especially fever, is absent in these patients. But anybody whose fever is lasting more than 3 weeks, that's something called fever of unknown origin or pyrexia of unknown origin, unexplained weight loss, lymphadenopathies, all has to be evaluated for tuberculosis. You need a very strong clinical suspicion, as many of the tests that we do, the MANTO, the IGRA, the tuberculin testing, all this can be falsely negative or will not elicit a response in tuberculosis in dialysis patients because of the energy that they have. So these patients has to be very critically evaluated and closely evaluated. All investigations and a diagnosis has to be made. So the extrapulmonary tuberculosis are also pretty common here. There's a GI tuberculosis, bone, genitourinary, tuberculous peritonitis, pleural effusion, pericardial effusions, and miliary tuberculosis are common. You need a strong clinical suspicion in these patients. So anybody who is having a fever of unknown origin for persisting fever, losing weight due to unexplained reasons, this diagnosis of tuberculosis has to be thought of. You have to search very proper clinical examination, do the blood, investigate with somebody who has a peritonitis, you have to get a tapping, and either a gene expert or a megabycal PCR has to be done. And if there is a lymph node or a biopsiable area, histopathological biopsy and a histopathological diagnosis has to be entertained. Viral infections like COVID, varicella, herpes zoster are common, and H1N1 and influenza viruses are also affect or the morbidity with these viral infections are much more in dialysis patients compared to the general population. All these viral infections has to be, many of these patients has to be isolated because in the units because the interpatient, because in the dialytic unit, the spread can be pretty fast between patients. Non-infective causes reactivation of the native kidney diseases, although many of these diseases burn out by the time the patient reaches dialysis. So some of them can have an active disease, especially lupus and vasculitis. Malignancies can present as fever, especially lymphomas or even a renal cell carcinoma. All those malignancies are notorious to present as pyrexia of unknown origin. Connective tissue disorders like rheumatoid arthritis. And there are a number of case reports with allergic reactions, especially drugs. Even there is a recent case report on heparin allergy causing persistent fever during dialysis. So all this has to be thought of a patient with fever when there's no cause can be ascertained. So coming to pyrogenic reactions in dialysis. So this is defined as fever and chills due to endotoxin bacteria in blood. So the pyrogens are different. For defined pyrogens, there are fewer producing substances introduced into the blood. Broadly, the causes can be either a contaminated water system, improper dialysis preparation, that resulting in a chlorines and chloramines in dialysis, contaminated bicarbonate, contamination of a machine, or improper dialyser reuse. So here the fever will be limited to dialysis days only. No obvious cause. Other cause. Multiple patients are infected together. The same growth from the blood as well as the RO water cultures, and the organisms of specific waterborne pathogens like Burkholderia stepacia, Stenotrophomonas multifida, Enterobacter cloacae, Pseudomonas aeruginosa, Ralstonia, Klebsiella again. So those who have gone through their culture reports to the RO plan will be familiar of these organisms. So if they remain above culture reports, they can levels above the colony counts can be above a particular level, that can cause pyrogenic reactions in these patients. The sources can be either from the primary water source, which is properly treated, the RO plant, the stagnation in the tank water, the distribution system, especially the piping circuit and loops, and bicarbonate precipitation, all the again improperly manufactured bicarbonate powder. So where does it maximum colonize? This is one of the studies that is shown that the endotoxin concentration across the dialysis water treatment system has been plotted. So as we can see here, the maximum is seen near to the carbon filter. Then it drops after the, again, reaches up to the recirculation loop. And once it reaches the piping, after the recirculation, it peaks again and again cleared off by the filter. So the maximum bacterial colonization in the carbon filter. So the post-pre-treatment system, if not working adequately, not functioning properly, it can cause significant endotoxin release or pyrogen release into the dialysate system. So again, that's all these which are part of our dialysis water treatment plan, like carbon filter, softener, deionizer, and effective RO membrane, all has to be properly maintained. So as we all know, here the RO unit and ultrafiltration removes bacteria and endotoxin, where the UV radiation kills bacteria but produces endotoxin. So the water storage tank, water distribution system, and the flow stagnation in the distribution system with biofilm formation is the main source. And to prevent this, you have to have a proper maintenance. The RO plan has to be periodically maintained as AMA or the AMA standards. There should be regular disinfection and descaling of the distribution piping system. The no dead ends. You should have maintain loops in the whole system, even at the end of the dialysis unit or the machine. You have to maintain a loop rather than keeping dead ends, and a timely change in the RO membrane and the ultrafilter membrane. So the dialysate at the end point also can be a source of infection as after bicarbonate preparation if the time lapses. So here the exponential rise in bacterial and toxin level in the bicarbonate, and there can be a transmembrane passage from the dialysate to the blood by backfiltration, back diffusion, or backleak. There can be either be viable organisms, bacteria, spores, fungi, or viruses, or microbial products like endotoxins or cytokine-inducing substances. And they cross the dialysis membrane to produce fever or chills of our patients. So let me summarize this. Fever is a vexing problem in dialysis patients and has to be treated. The cause has to be identified and treated. The commonest cause is catheter-related infections, eminently preventable if we educate the patient, if we ourselves as a healthcare provider take adequate precautions. But it is not the only cause. You have to have a high index of suspicion for other infections, especially tuberculosis and food infections. A lot of other bacterial infections can be in these patients. And finally, pyrogen reaction dialysis, again, eminently preventable, but it requires a wholehearted approach to find out its source and manage it efficiently. Thank you for your patient hearing.